Hello, everyone. I'm super excited for you guys to listen to our next guest. He is a podcast host, an ICU and palliative care physician, and his podcast is called Solving Healthcare. I love the title, and his name is Dr. Kwadwo Kyeremanteng, and I'm just really excited for you guys to listen to this episode. We talk about what got him into medicine. We discuss, his work in ICU care and in palliative care. We discuss his podcast, Solving Healthcare, and he talks about some very interesting topics around, ways to improve efficiency, ways to enhance the healthcare experience. And he's just such a fun, energetic guy, and I love this conversation. So I want you to really listen in and take in a lot of this conversation. It was so much fun to have Kwadwo on, and I'm looking forward to touching base with him later in the future. So, enjoy this episode. So much to discuss, so much to think about, and I hope you enjoy the content. If you enjoy this episode, I want to ask you to check out the Solving Healthcare podcast. I think that it's just so important for us to listen to these conversations and understand more about the healthcare process and what we can do to advocate for our patients, our community, and enhance the healthcare experience. Without further ado, I hope you enjoy the episode. Hello, everyone, and welcome to another episode of The Happy Doc. I am pumped. I'm usually pumped, but I'm even more pumped. Let's get it. Because I'm with Dr. Kwadwo Kyeremanteng. Did I pronounce that right?
Yes, nailed it. You nailed it, Taylor.
And he is an ICU physician. He does palliative care work, and he has a podcast called the Solving Healthcare Podcast. And I'm absolutely pumped to have Dr. Kwadwo with us today. How are you doing, man?
Excellent. How are you doing?
Fantastic. I'm ready to go.
Can I just say one thing before we get started?
Yeah, let's go.
What you're doing is straight up balling, buddy. Like, I got to commend you for putting on such a great podcast on how we collectively as docs could be more resilient, be more, feel more content with our work. And I got to tell you, I'm proud of what you're doing. And it is a true privilege being on this bad boy.
Wow. I'm going to take a second. I'm going to give myself a pat on the back. We did it. My work is done here. I think the podcast is over,
We'll see you later.
All right. So let's get into this. So Kwadwo, I'm always excited to speak to a physician, but at the beginning of all of this, you didn't choose an easy field, right? You didn't go into something easy, especially with you, ICU, palliative care. You're working with death, right? Mm-hmm. So instantly my mind is like, this is some intense person right here. Like, what was it that, inspired you to kind of pursue this pathway? Yeah.
So great question, Taylor. To be honest with you, the ICU side was the fact that I don't like predictability. I don't like a 9-to-5 job where you know what's to expect every day. Like, I have two sisters that are dentists, for example, and I know my parents thought that was my calling, but I couldn't even stand the thought of doing that for, a year. And the joy of ICU is how challenging it is, and the fact that you don't know what's coming, from 1 minute to the next. So 1 minute you could be talking to a family about, how their loved one is passing away, and 2 minutes later, a sick trauma or an upper GI bleed could be coming in, and you got to be focused. You got to be in the moment, and you got to lead, and it's awesome. It really is. And one part of the job that people don't realize in terms of intensive care is how really team focused it is. And you need to be able to have some leadership skills and really, communicate well with your team. You need to check in with your team, make sure that they're doing okay. And all these elements make the job extremely challenging, but extremely gratifying. Yeah. And then my other job when I do palliative care is, a lot of people say, it's like, so how can you do that? It's so depressing. Patients are dying regardless of whether I'm there or not. And
right.
I'm there to make sure it's the least painful experience as possible, not only for the patient, but also for the family.
Mm-hmm.
And I can't tell you how rewarding it could be when, one, you allow a patient to have a peaceful death, but also having that privilege of being with the families and the patient near the end of life, where you're sitting down with, Grandpa Gerald, and talking about how he says dirty jokes at Christmas over at the dinner table, and you get to sit in on those moments and smile and hold hands and just be a part of that. Like, it truly is a privilege, and it's and so that's part of my job, where I have a lot of gratification from it. So there's a lot of good, and unfortunately there's also some bad with it. But
and just out of curiosity, like with that work, like what's the ratio? Are you doing mostly ICU, little palliative? Like, how does that end up working out?
Yeah, I mean, I used to do it about half my time in each, or about I'd say 60-40, 60 ICU, 40 palliative care. And that my palliative has slowed down a bit because of my research program, and then also doing the pod has been pretty time consuming. So that has slowed down a bit, but it's part of the. I hope it continues to be part of my career.
No, that's great. And, I share a little bit of experience in palliative care, because in psychiatry, we get to choose some electives. So I got to do a couple weeks with palliative care. And as the physician I worked with would say, the hardest part is dropping the hammer, he would call it. And I'm sure you've heard that before too, which is like, for example, I think a lot of, and I know you know this, like a lot of times, like physicians or families want to tiptoe around the truth. And there's that moment where you drop the hammer and you say, it's likely that, this is going to result in death, or it is, it is going to result in death. And I had one of those experiences where I had to tell, a family that, that was what was going to happen. And, it's a very interesting space to be in, to be the person that says it. You know what I mean? And that's challenging. Like, how do you deal with that?
To be honest with you, I honestly at times feel like I'm doing them. I don't know if this comes across harsh, but sometimes I feel like I'm doing them a favor, because what I see in both palliative and in ICU, when we don't address it, bad stuff happens. You know what I mean? Like, say, for example, you're somebody with late stage cancer and you've never been told clearly that this is terminal, or you're going to die from this. You got a relative that lives in Australia that you haven't seen in a while. Without that reality check, maybe I'm not calling that daughter. Maybe I'm not having that quality time I would be having in my last few months of life.
Right.
Maybe I'm not having those deep conversations and expressing, how much I love my loved one or whatnot. I mean, this might be too personal, but my old man passed away about a year and a half ago, and he lived overseas in Ghana, and one of the biggest regrets I had is that he died unexpectedly. Didn't get a chance to say goodbye, and this is the thing that we're doing to our patients by not giving them the truth or not being accurate. And the other thing that it does too on the ICU side is that then you might be receiving care that would be more aggressive, or what you'd be less likely to go through if you knew what your prognosis was. Because going through an ICU admission, like, it sounds like, okay, I'm just going to be on life support for a while, whatever.
Right.
Like, it is not benign. It is, people suffer.
Right.
This is true. This is a truly difficult experience where you can't even scratch your nose because you might be being tied down. Someone wants to make sure you're not pulling at tubes. You have the driest mouth in the world, and you would be begging for a glass of water. You can't express if you're having pain because you're sedated, and so all these things are difficult and could be considered suffering. And if we're not being honest with our patients, this could be the road they go down.
Yeah.
And so this is why I honestly, like, you know, everyone's a bit different, but in some ways, like it's less difficult for me to drop the hammer or give the truth.
Yeah.
Because I know what the future will look like if you don't be truthful.
Yeah, I want to thank you first off for sharing the personal story, you know, with your own father. That's really powerful. And you know, you in terms of the ICU, you know, you remind me of like when I see these patients in the ICU who are like post intubation or even like, you know, they're breathing out of a tube and what have you. It's not fun. It looks uncomfortable, and you know they're in a lot of pain. So I think from a patient's perspective, you can only like, you know, you get to see this every day, but from a family member's perspective, someone in the community, they don't get to see that side of it, that it is very painful. So I think it's really insightful and important that, you know, kind of highlight that. The other thing to just consider in all of this is, yes, it's difficult to speak to families about this, but you bring up such a powerful point again that, you know, if you tell them soon enough, then family can travel, family can come in, and you can have that communal sort of experience where everyone comes together. And I'm sorry to hear you didn't have that. That sucks.
Yeah, no, I appreciate your kind words, Taylor. But I mean, it's one of those things. It would be nice, but it's just wasn't possible. And but you know, like expressed it to you and your listeners now, but it's something I even tell my patients, you know, when it's appropriate. Like it's one thing that one of the gifts that I've received, I guess, from my old man passing is that I feel like it allows me to connect even more when it comes to these end of life discussions, because I've experienced it, you know, and so, you know, when I hear about, you know, a family member that had, you know, difficulty with their loved one, I often say, like, listen, buddy, if this was what happened to me, and I would have done anything to be able to be there for my old man, because you know, it just, so, you know, it's allowed me to be more connected with my patients, which is what to be honest with you, what we're here to do, and what makes the job experience way more gratifying, and what creates, you know, a happy doc is that connection.
No, I mean, you dropped the name there. No, I thank you. I didn't have to pay him for him to say that just now. No, but no, I really appreciate the, you know, it's powerful, and I'm very thankful you shared that. You know, and you know, I don't know if this is a good segue, but, you know, you've seen so much, right? In the work that you do, you are seeing the sickest and you're having these conversations. And I'm sure that's obviously connected to your podcast, Solving Healthcare. And you had just told me before we started recording, of course, that you started this recently, like about a half a year ago. What you know, led you to this next step? What kind of inspired you to say, you know what, maybe we should have these conversations?
Yeah, no, thanks for that, Taylor. You know, it really was the fact that we had this research group called Resource Optimization Network. And my passion in terms of research has been like, how do we make our healthcare system more sustainable? How do we stop spending ridiculously on things that aren't affecting care? And we've been pumping out these papers for 3+ years, you know, high profile papers, and not a lick has changed. You know what I mean? Like nothing's changed. And I'm like, what is the point of this? If we keep doing, we go from one project to another and nothing's changing. I'm like, we got to do something different. We got to like increase the awareness of some of these issues. And so I was like, I enjoy listening to podcasts. I said to the crew, I'm like, why don't we just try podcasts, see what happens? And buddy, it's been a game changer. It's been like, in so many ways, like we talked before, about how it's a creative release. And, you know, if any of you guys ever listen to our show, you'll hear, like, I I do get a little ridiculous. My kids do some of the intros. Like it's a creative release for sure. But also, it's been so rewarding in the way that, stuff is actually changing. Like we had a show on about, child psychology, how child psych services aren't available or they're super expensive and a lot of people can't afford them. Mm-hmm. And what came out of that is now there's one of the child psychologists is doing pro bono work for group that's for kids that can't or families that can't afford it. And like, wow. That's like one little drop in the bucket, but it's more than any of the research I've done so far has done. And, and I'm just like a small cogwheel in this. And I don't even know if that's an expression, but sorry.
No, it's all right.
But but at least there's some talk. There's at least increased awareness. At least there's some change. And like my passion always is like the true driver of this has been on futile or I guess I'll use the term futile patient care. Like when we admit patients that we don't think are going to benefit from ICU care, and we just feel like our hands are tied. Right. The impact that has on healthcare, the impact it has on healthcare providers, the impact it has on family, the impact it has on cost. That was the true baby that's spurred all this on. Yeah. And, showing when I tell people that 1% of your gross domestic product goes to ICU care, when I give numbers like, in one of our hospitals, we had 12 patients that were deemed quote unquote futile, that cost the system $8 million and that are all passed away now, that represented 10% of our ICU budget. When you give numbers like that, people's eyes open and they start to really question, what are we doing? What are we? Should we be having more in-depth conversations with our loved ones about what they would really want? And so, I feel like it is putting there is some impact there now doing the show. So that's been a bit of the journey. That's a long-winded answer. Sorry, Taylor.
No, it was a great answer. I'm just like still thinking about it, but like when I'm thinking about what you just said, right? Like with end of life care, for example, and the cost you gave, you said $8 million, for example, with these patients that you knew basically
12 patients, by the way.
12. Right. 12 patients. That's crazy. That's what is that? $750K. Yeah. So that's a huge number. Right. And to think, on the other end, if it was my family member, we always say, if it's your family member, you'll do whatever it takes to save their life. But it's such a difficult conversation, from the medical side of things, is when does that, again, it's almost like a philosophical question, but when does that switch, right? Like when does it switch to, this is someone who is viable and we're able to still help, versus now it's becoming a situation that's futile. We don't need to go into this whole conversation, but it does, and that has a huge impact on cost. But, I'm going to switch this over for a second. With the Solving Healthcare podcast, it sounds to me like something you're tackling is dealing with these kind of difficult situations and not just helping the patient, but helping the healthcare process, right? Mm-hmm. What are some, you mentioned the pro bono work with, child, psychiatry as an example, but what are some of the lessons you're learning? What are some of the things you weren't even aware of? But maybe now that you're doing the podcast, you've learned more about?
Wow. So that was a great question. First, I just want to address the futile point real quick. So in that example I was giving about the 12 patients that cost $8 million, most of them, if not all of them, they had previously expressed wishes that they would not want aggressive care like they received. So it's not even where, the healthcare team is saying, oh, if it was me, I wouldn't want that, which predominantly, I think most healthcare providers were of that sentiment. But it was like most of these people had said, like, I wouldn't want to spend the rest of my life on a ventilator, and they were still getting that. And one thing I think when it comes down to deciding what's appropriate and what's not is, what is the goal? You know what I mean? Like if grandpa says, I want to live at all costs and, I have good quality of life despite not being able to, do all the things I want to be able to do. That's one thing. But if they said, grandpa or grandma said, I love golfing, I loved knitting, I love interacting with my grandkids, and if I'm not able to do that, then I don't want to be going through this torturous experience. That's another thing. And so most people lean on the latter. So that's where I think some of that balance comes into play. And then your awesome question about what I've learned, I don't even know where to start. I got to tell you, every show, I'm just like, my mouth is open. One of I would say this one, the patient experience material, like when I talk about talk to or interview a patient and I learn about what makes their patient experience more valuable or what has hurt in the past, man, it's so eye-opening. It is so eye-opening. Like, and it's changed my practice. It's like I had one guest that was saying she had a kid that had cancer who's healthy now. And they were going through, it was a Sunday and it's skeleton staff on the weekend. And she's used to the team rounding and they were busy and her son was doing well. So the team didn't come by and just say hello and whatnot. And that just like not having that routine for her just kind of like was so anxiety provoking. So I was like, to me now, I try to always do that with my patients because in case just from hearing that from Jen McComb, that, it really stuck with me, and so often it's the little things that can make a difference when they tell you like how much it meant when the doc sat down at their level and held their hand when they were giving bad news. Like, these things make a huge difference. And, so that's one thing. And you don't realize some of the difficulties outside of the hospital too. Like one of another one I did interviews was how, you set up like these home care services and you discharge patients and so many things could fall through the cracks. And so that, how much of a strain it could be on the family, not having that home care services they said they were going to be there at 3:00 and they don't show up. And, like all these things that can really affect patient care. And then one last thing I'll say is this one that really hit home with me is I have an episode coming out soon on Indigenous health and what atrocities happen within my own country to our own people is baffling. It actually just legit, Taylor, blew my mind. The fact that 4 12-year-olds committed suicide in a small town, and it got hardly any press. The fact that, they get 30% less money for education. The fact that if they go and deliver a baby and it's somewhat complicated, they don't get to bring a companion. They got to do that on their own. And these are often young, very young patients. Like I won't get into everything because I could talk about it forever, but it just broke my soul hearing some of this stuff. But it just left me, a lot of this stuff left me, like the overall lesson is we could do better. I could do better. We collectively as clinicians can do better as a society of like when it comes to, trying to provide the best care for patients, we can clearly do better. And so, so many lessons, buddy. That's a great question.
No, I love it. And, it's just, I love the title, by the way, Solving Healthcare, because it's definitely powerful. Like, what are we going to do? What awareness can we bring? You talk about podcasting and awareness, that by knowing this information, what can we do to change it to improve, like you mentioned, the patient experience, the experience for people such as, you brought up Indigenous people, what do we do to enhance the healthcare experience so that we can really optimize and do a really good job for, patients and healthcare as a whole. So, question I would ask anyone, but obviously you with the podcast, I would love to hear your, 30 seconds to a minute pitch. Why should we listen to your podcast?
Why you should listen to the podcast? Because we all have something invested in healthcare, all of us. And, when it comes to one of the things that caught me too is, you and I are very much in acute care. And a lot of the problems that we could improve on is we could intervene on way earlier. Like prevention is key. And even interventions that can involve our kids are key. And so here on this podcast, you're going to learn about what these issues are, what you could do about it, what simple interventions could make such a huge impact on your life, on your family's life, on the system. And it really, some of these things that we talk about, it's not genius. But just by listening, if I'm going to say one thing, if we just listen, truly listen, and when it comes to some of these issues, you're going to get engaged. You're going to want to be involved. You're going to want to do better. So I'm hoping the show, what it'll do is inspire listeners and create that change. Essentially solve healthcare, baby.
I love that. I love that.
Yeah.
Thank you. That was a fantastic, pitch, and I'm inspired to hop on and listen to like 10 of those episodes. So that's great. So, we've had a conversation. We've got to learn about you, some ICU care, palliative care. You've talked about your story, talked about your podcast. Is there something you feel like you're passionate about, you wanted to just throw in here, make sure that, there's no way you could leave this episode without talking about this? What would that be?
Yeah, I it's something along the Happy Doc lines is, and that I try and teach my residents, my students, I do mentor a lot of the kids, is that do your best to keep your soul in medicine. Try and stay your authentic self, man, because it's so easy to lose yourself. You are in medical school, you're doing all this shit to try and, are you allowed to cuss on the show?
Yeah, cuss away.
Okay. Yeah,
throw in some fucks, throw in some shits.
No, you got to do your darndest to keep your soul, because, as a med student, you do all this shit to try and please your resident, your fellows, your staff. Then you get that staff or your into residency you get, and you still try to please your staff and other fellows. Try not to piss off nurses and allied health professionals. You're doing all this crazy call. You're not sleeping. You're not eating well. And then before you know, you get that fellowship or your staff job, but you don't want to ruffle too many feathers. And honestly, if you be yourself, if you show your true self, you'll be attracted to places that will accept you, that will allow you to be who you need to be, and you will be so much happier. You will be so much happier. I think we don't do a good enough job at letting people be them, or encouraging people to be their true selves. And, this is what's beautiful about this podcast, man. Like, you're encouraging that. You're encouraging people to use that creative side. That's another thing for me. Like, we talked offline about how creativity really can show your true self and allow you to achieve some contentment and some happiness. And that you got to make time for that, and like for me personally, that's hockey. I play a lot of sports. I go to the gym a lot. Yeah. I love to laugh. Like, we forget to laugh at times, like, if you ever, hopefully we never have to work together, I guess. But, one of the parts of my job is I like to make my crew laugh. I like to make sure that they have a smile on their face. And even though this is a very stressful job, but you got to be able to unleash some of that tension sometimes. And so, that would be the one thing, is like, find yourself and don't lose yourself despite your medical journey, because it's so easy to do that.
Wow. So Dr. Kwadwo, I love that response. I don't even want to finish with anything else besides that. I want to thank you for being on the podcast. And I'm going to provide all of the links in the outro. I'm going to talk about all the ways we can find Dr. Kwadwo. And I want to thank everyone for listening to this episode.
Well, I really appreciate you having me on, Taylor. Thank you so much.
All right. And take care. Well, that's the episode for today. I hope you enjoyed it. If you want to show some love to Dr. Kwadwo, go to his Solving Healthcare podcast. Take a listen to some of the episodes. And something to support all podcasters is to leave a 5-star review, especially on iTunes or whatever platform that you use. It just shows love for the podcast and what we do. So please leave a 5-star review on the Happy Doc if you enjoyed the episode. And if you are inclined, share this episode if you felt like it was a good one, and you felt like you had some good information and that it was valuable. So I appreciate your time, and I'll see you on the next episode.